So, thank you very much. I really do appreciate this award, and I'm pretty sure it will affect my future career as well. Well, being on a stem cell meeting might be pretty provoking to have this kind of title. Since I'm not a stem cell researcher in the first place, but a consultant of neurology, I think I can choose this title. I don't want to talk about the paper that has been awarded, but I rather want to talk about the things that we did back in the day and the things that we want to do in the future. And to start off, I first want to introduce or talk a little bit about stroke. As you all know, or hopefully know, the current concept of cerebral ischemia or stroke focuses on 3 columns. That is the admission of the patient towards the stroke unit, the thrombolysis, and the endovascular treatment paradigm. Unfortunately, these therapeutic options are limited due to side effects and a very narrow time window, and that is the reason why people since about the 1990s have been trying to develop new therapeutic strategies. So the basis of these experimental treatment paradigms is the pathophysiology of cerebral ischemia as depicted there on the slide. And indeed, there were quite a few papers, as a matter of fact, 700, 800 papers using experimental stroke models that could show neuroprotective effects with various drugs. Unfortunately, none of these experimental treatment paradigms have been successful in clinical trials. There's a number of reasons. I don't want to go into details. So the focus has now switched towards studying neurogenesis, and the basis of this is the fact that endogenous neurogenesis persists in the adult brain as well. So as you can see here, there is quite a few stem cell niches, and one of them is the so-called subventricular zone in which the neuroprogenitor cells reside. Upon induction of cerebral ischemia, these cells, these NPCs, migrate towards the site of lesion where they proliferate and finally differentiate into neurons. The problem with this approach is only that both survival rates and differentiation rates of these cells are pretty low. So if you want to use this kind of phenomenon neurogenesis, you have to manipulate these cells. How can you do that? Well, you can protect the NPCs by enhancing the resistance within the ischemic milieu, or what you can also do is you can try to stimulate NPCs per se. And that is, for instance, what we did back in the day by injecting a viral vector that contained a microRNA, in this case the microRNA 122, which induces a neuronal phenotype during ontogenesis of the brain. So we injected this viral vector about 3 weeks before stroke in our mice, and indeed on day 28 and 56 we observed a higher neuronal differentiation rate of these newborn cells. Neurogenesis goes hand in hand with angiogenesis, and in these very same animals we also observed a higher amount of CD31 expressing cells, thus indicating angiogenesis. So this approach was pretty beneficial for the animals. You could also achieve these very same or similar results by interfering with the afferent B3 pathway. These are proteins that are important during the ontogenesis of the brain as well, especially during axonal projections. And knocking out the afferent B3 pathway also resulted in a higher amount of neuronal precursor cells or neuronal cells within the ischemic lesion site. None of these approaches is really useful for clinical trials. So there's another way how to manipulate endogenous neurogenesis, and this is the transplantation of NPCs. So you can obtain these NPCs from the subventricular zone and put them into the culture dish. They will form neurospheres, and you can easily transplant these cells in mammals. The problem with this approach also is that you have low survival rates and very low differentiation rates of these grafted cells. So again, you have to manipulate these cells. This is a work where we enhance the resistance of these grafted cells by in vitro transduction using TET-HSP70, so a chaperone that will increase the resistance of these future grafted cells. And then we transplanted these cells intravenously or intracerebrally. I don't want to go into detail, but what you can see is, for instance, that when you intravenously transplant these cells, the blood-brain barrier integrity is enhanced when you, for instance, transduce these cells, and also the reperfusion injury in these animals is reduced. When you transplant these cells intracerebral, for instance, what you can observe then is that you have a change within the ischemic micromilieu. In this case, you have increased concentrations of growth factors, which also gives you the hint that these transplanted cells are not really integrated within the residing neural network, but they act in a paracrine way. And that is the reason why we basically came to the approach that has been published in Stem Cell Translational Medicine. So a few years ago, people thought that the trophic factors, which are secreted by the stem cells, are the decisive mediators, but there is recent evidence that it might be vesicular structures which are more important, or that are the decisive mediators of stem cell actions. So these vesicles are called extracellular vesicles. They can be differentiated into various subvesicles, such as microvesicles, exosomes, and so on. They differ in terms of diameter, origin, and also in terms of contents. And they are virtually secreted by any kind of cell. So we wanted to know, are these extracellular vesicles, these EVs, just as powerful as, for instance, mesenchymal stem cells, or maybe they are not stem cells at all, as we have just heard from Dr. Kaplan. Either way, these stem cells act in an indirect way. So if they act in an indirect way, maybe the EVs will do the job as well. And that is what we started in our stroke model of mice. So in this model, we injected mesenchymal stem cells, or EVs, intravenously on day 1, 3, and 5. And we observed these animals for as long as 28 days. And then we scored them on various time points using behavioral tests. And what you can see here is that, first of all, the mesenchymal stem cells do their job. Animals that got the MSCs have a better functional score as a saline control. But also the EVs, or the animals that got EVs are also just scoring as well as the MSC groups. So EVs are not inferior as compared to the MSCs, which is just what we were hoping for. The mechanisms that are involved in this process are not neuroprotection. What the EVs most likely do is they modulate post-stroke immune responses. So this is flow cytometry from blood samples on day 6. What you can first observe is that within the stroke mice, you got an immunosuppression as compared to the sham control. And what the EVs do here is they kind of reverse the post-stroke immunosuppression, as you can see here for the natural killer cells, the T lymphocytes, and the B lymphocytes as well. So this is most likely the way they kind of work. Question now is this feasible in men? Well, we haven't applied EVs in stroke patients yet for obvious reasons, but we were the very first worldwide who actually applied EVs in men at all. And this is a patient that was suffering from a hematological disease, and this patient got a bone marrow transplantation, and unfortunately in the process of this transplantation, the patient developed a graft versus host disease, which can be usually treated using glucocorticoids. In this case, the patient didn't respond to the glucocorticoid therapy. So what you can do then is, in experimental approaches, you can inject or transplant MSCs. We decided to inject EVs instead of grafting MSCs. And these EVs were given continuously for over 2 weeks. And what we then observed was that both the rash and the frequency of diarrhea was significantly decreased. The patient died in about 6 months later, but not because of the EVs, but because of pneumonia. I don't want to say that the EVs actually cured the rash and the diarrhea, but at least we could say that they were tolerated in men. So this makes me pretty optimistic that we can use EVs for stroke patients in the future as well. But before we do that, and this is my last slide, there are many questions to be answered. First of all, we don't really know what is the optimal isolation procedure for EVs. There are many procedures that people can use. Many use ultracentrifugation techniques. We have used precipitation, the so-called PEG precipitation for the project I was just briefly describing. The next question is then, how do we actually characterize these EVs? There's not a single marker which is specific for EVs. And then, of course, we have to further analyze these EVs in terms of therapeutic potential in vitro. And then later on again, we have to further understand what is the real mechanism behind the EV beneficial or the EV induced outcome. Thank you very much for your attention.